You've had your blood pressure taken 100 times, maybe more. You sit down, they wrap the cuff around your arm, it squeezes, it releases, and then someone reads you two numbers, and you nod. You nod. Not because you understand what the numbers mean, but because nodding is what you do when someone hands you information in a tone that doesn't leave room for questions. And the strange thing is, you've been nodding for years, maybe decades. You know one number should be lower than the other. Somewhere around 120 over 80 is good. Yours is higher than that. Maybe a little, maybe a lot. And your doctor has mentioned it, adjusted something, mentioned it again. But here's what I want to ask you honestly. Do you actually know what those two numbers are measuring, not top and bottom, not systolic and diastolic? I mean, do you know what is physically happening inside your body when each one is recorded? Because most people don't. And I don't say that as a criticism. I say it because the system, the 12-minute appointment, the cuff, the printout, was never designed to explain it. It was designed to record it. And recording a number without understanding it is a little like reading the temperature on a thermometer in a foreign language. The information is there. It just isn't reaching you. I want to change that today, completely. Because once you understand what these two numbers actually measure, what they represent in your body, specifically at this stage of your life, you will never look at a blood pressure reading the same way again. And more importantly, you'll know what question to ask that almost nobody is asking their doctor right now. There's a man I want to tell you about. His name was Victor, 71 years old, retired electrician from outside Pittsburgh, the kind of man who fixed things, his own car, his own roof, his neighbor's fence without being asked. He wasn't a complainer. He wasn't the kind of person who called the doctor every time something felt off. He went when something was broken. That was the rule he'd lived by for 50 years, and it had served him reasonably well. 2 years before I met him, he'd had what his doctors called a minor stroke. TIA, a transient ischemic attack, temporary loss of speech for about 4 minutes while he was standing in his driveway. His wife saw it happen. She described it to me later as watching someone she knew suddenly become someone she didn't. After that, Victor followed every instruction. Blood pressure medication twice daily, no more salt on his food, walking 40 minutes every morning, even in winter, even in the dark. He came to see me 6 months after that first appointment. The cardiology visit had gone, in his words, fine. The numbers were pretty good. His systolic was still running around 148, which wasn't ideal, but his diastolic was 68, and his cardiologist had noted diastolic within acceptable range. Victor sat across from me and said something I've thought about many times since. He said, "I keep doing what they tell me, but I still feel like something's not right. I don't know how to explain it. I just feel like the machine is saying one thing and my body is saying something else." I asked him to show me his last 5 readings. 148 over 68, 152 over 70, 144 over 66, 150 over 68, 146 over 64. I looked at those numbers, and I felt something I can only describe as the specific discomfort of seeing something clearly that had been missed, because every single one of his cardiologists had looked at column 1 and column 2. Not one of them had calculated column 3, the gap. 148 minus 68 is 80. 152 minus 70 is 82. 144 minus 66 is 78. His pulse pressure, the distance between those two numbers, averaged 80 millimeters of mercury. The cutoff for elevated cardiovascular risk is 60. Victor's body had been sending a signal for months. It was right there in the numbers, hiding in the space between them. And because nobody had been trained to read the gap, nobody had read it. I'll come back to Victor, because what happened next in his case is the thing I actually want you to understand. But first, I need to explain what those numbers really mean, so that when I tell you the rest of his story, you'll feel what I felt when I looked at that printout. Your heart is a pump. You know that. Everyone knows that. But let's make it specific, because the specific version is the one that changes things. Your heart doesn't beat continuously. It beats, pauses, roughly once per second for your entire life. Each beat is a contraction, a squeeze that sends blood out into your arteries under pressure. Then the heart relaxes, fills again, waits, then squeezes again. The first number, the systolic, measures the pressure in your arteries during that squeeze. At the peak of the pump, the moment of maximum force. The second number, the diastolic, measures the pressure in your arteries during the pause, when the heart is resting, between beats. That's it. Top number, pressure during the push. Bottom number, pressure during the rest. Now here's where it gets important. Your arteries aren't rigid pipes. When you're young, they're elastic, like a rubber band. Every time your heart squeezes and sends a surge of blood outward, the artery walls stretch slightly to absorb some of that pressure. They give a little, and then, during the pause, they spring back. And that spring back itself helps push blood forward toward your organs, toward your brain. So there are actually two pumps working together, your heart and your arteries. And that's why it feels the way it does when it works right. That's why you don't feel every heartbeat as a jolt through your body. The arteries are absorbing the shock, smoothing it, maintaining steady pressure through the pause. But here's what happens after 60. Those artery walls start to stiffen, not dramatically, not all at once, gradually, over years, over decades. The elastic tissue in the artery walls gets replaced by something less flexible. Calcium deposits form, collagen crosslinks, the walls lose their give. And when that happens, everything changes. The systolic goes up because the walls no longer absorb the push. The full force of the heartbeat hits rigid pipes instead of elastic ones, and the pressure spikes higher. And the diastolic goes down because the walls no longer spring back. The secondary pump is failing. Between heartbeats, the pressure drops further than it should. Higher top number, lower bottom number, wider gap. So it's not in your head. There's a reason the numbers look the way they look. And once you see what's driving them, you can't unsee it. The gap, what doctors call pulse pressure, is a direct measurement of arterial stiffness. It's the body's way of printing a record of how elastic your arteries still are. A gap under 40, healthy, flexible arteries. A gap of 40 to 60, the normal aging range. A gap over 60, elevated risk. The arteries have lost significant elasticity. Each heartbeat is landing harder than it should. Every point above 60 is associated with measurably increased risk of heart attack, stroke, and cognitive decline. Not might be associated, is. This is one of the strongest predictors in cardiovascular medicine, and almost no patient has ever been told this number exists. Here's the pattern I see most often in my patients over 60. Someone comes in with a systolic of 145. That's high, above the 130/80 target the American Heart Association recommends. But their diastolic is 72. And somewhere in their chart, someone wrote diastolic acceptable. And that note has been quietly reassuring everyone ever since. No one calculated the gap. 145 minus 72 is 73. That's not acceptable. That's a significant signal. But the note says acceptable, so it stays. Have you ever looked at your blood pressure readings and focused entirely on the top number? Because that's the one your doctor always mentions? Most people do. Most doctors do. It's the number in the guidelines. It's the number the medications target. It's the number that determines whether you have hypertension. And it matters. Absolutely it matters. But the bottom number isn't just a reassuring footnote. When your diastolic is dropping, when it's 70, 68, 65, 62, while your systolic keeps climbing, that widening gap is telling you something specific. It's telling you your arteries are stiffening. It's telling you the elastic pump is becoming a rigid pipe. And the lower your diastolic falls relative to your systolic, the harder each heartbeat is hitting the walls of those pipes. And the harder it's hitting the delicate filters and vessels of your brain, your kidneys, the back of your eyes. Let me give you an analogy that makes this click. Imagine your arteries as a garden hose, but a very specific kind of hose. A new hose, the kind that's been sitting in a garage for 2 or 3 years, still flexible, still willing to expand a little under pressure. When you turn the tap on full, the hose swells slightly. It absorbs some of the force. The water comes out in a steady stream. Now imagine the same hose, but old, sun-damaged, brittle. You leave it in the yard too long and the rubber starts to crack and harden. When you turn the tap on full, it doesn't swell. It can't. The pressure has nowhere to go except straight through. And the stream that comes out doesn't flow. It surges. And if there's any narrowing, any small obstruction in that brittle hose, the surge hits it like a hammer. Your heart is the tap. Your arteries are the hose. When they're young and elastic, they absorb, they smooth, they help. When they stiffen, every beat is a hammer, and the gap, your pulse pressure, is the measurement of how hammer-like each beat has become. Now, about Victor. I showed him his pulse pressure. I drew it on a notepad, his 5 readings, the 2 columns, and then a third column, the gap, 80, 82, 78, 80, 78. He looked at it for a moment. He said, "So the diastolic being low isn't good news." I said, "It means your arteries are stiff. It means the elastic pump isn't working the way it was. Your heart is working harder per beat than it should be." He was quiet for a moment, and then he said, "My cardiologist looked at these exact numbers and said my diastolic was in the acceptable range." I said, "It is in the acceptable range for a 35-year-old. The question is what it means in combination with your systolic at your age after a TIA." He picked up the notepad, looked at the third column. He said, "Nobody ever showed me this column before. And I want to be clear about something. I'm not telling this story to criticize his cardiologist. His cardiologist is likely excellent. The system they work in gives them 12 minutes. The guidelines they follow emphasize systolic targets. The third column isn't in the standard checklist. I'm telling this story because Victor, a man who had already had a warning stroke, who was doing everything right, who was being monitored, had a critical cardiovascular signal sitting in his own lab records, visible, unread, for 2 years. Not hidden, not obscure, right there. And the only thing standing between that signal and someone acting on it was knowing the gap existed. Victor's cardiologist reviewed his records after that visit. They adjusted his medication, specifically targeting the arterial stiffness component, not just the systolic spike. 6 months later, his pulse pressure had dropped to 64, still elevated, but moving in the right direction. He told me later that what changed wasn't just the numbers. It was that he finally understood what the machine was saying. His body had been right. Something wasn't right. And now he had the vocabulary to explain why and to have a different kind of conversation with his doctors. That's what I want for you. So let me make this practical. The next time you see your blood pressure reading, whether it's at the pharmacy, at your doctor's office, on your home monitor, I want you to do one thing before you do anything else. Calculate the gap. Take the top number, subtract the bottom number, write it down. Under 40, excellent elasticity, 40 to 60, normal aging range, keep monitoring. Over 60, bring this to your doctor specifically, not as a side note, as the main thing you want to discuss. Say exactly this: "I've been calculating my pulse pressure. It's consistently over 60. I'd like to understand what that means for my specific situation and whether my treatment plan accounts for it." That's it. That's the sentence. It will start a different kind of conversation than the one you've been having. The second thing, and this one is harder, but it's the one that makes the biggest difference long term. Blood pressure isn't a single reading. It's a pattern. A single reading in a doctor's office is almost meaningless on its own. What matters is the trend. What matters is the variation. What matters is whether your numbers at home match your numbers in the clinic. Because for roughly 1 in 4 people over 60, they don't. The number the doctor sees is not the number your body lives in. This matters so much that medicine has a name for it: white coat hypertension. The anxiety of the clinical setting pushes the number up. The doctor treats the number they see, and the actual number, the one your arteries experience at 11 p.m., at 6 a.m., during a walk, during an argument, nobody is seeing. Which is why, if you don't have a home monitor, this is the moment I would ask you to consider getting one. Not an expensive one, not a complicated one. A validated upper arm monitor, not wrist, taken at the same time each day, in the same position, after 5 minutes of sitting quietly, both morning and evening if you can. Because the number your doctor sees once every 3 months and the number your body lives with every day, those can be very different things, and treatment should follow the number your body lives with. Talk to your doctor about starting home monitoring and bring your readings log to your next appointment. Ask them to look at the trend. Ask them to calculate the gap with you. They may already know all of this. Many do. But giving them the data, giving them your own careful record, changes what they can see. The third action, the one I want you to sit with. If your diastolic has been dropping over the past few years, even while your systolic was being managed, that trajectory is information. It means the gap is widening. It means the pipes are stiffening. It means the current treatment may be targeting the symptom without addressing the mechanism. Bring that trajectory to your doctor. not just today's number. The trend over the last year, 2 years, 3 years. My systolic has been treated, but my diastolic has been dropping. Here's the trend. What does that tell us about my arterial health? That question will land differently than my blood pressure is a little high, because now you're describing what's actually happening, not just what the top number says. Victor still sends me a message every few months, a photo of his morning readings. He calculates the gap himself now, every time. He's tracking the trend. He knows what he's looking for. He told me once, and I think about this whenever I sit down with a new patient, that he spent 2 years feeling like the machine was saying one thing and his body was saying something else. And now he knows they were saying the same thing. He just finally had someone translate it. You walked into this conversation already knowing something was worth understanding. You've been carrying those two numbers for years, maybe decades, and something about them never fully clicked. Now you have the third number. Now you have the gap. And the next time someone wraps a cuff around your arm and reads you two numbers, you'll know exactly what to ask. There's something I've been thinking about as I put this together, and I want to leave you with it. Victor's most important reading wasn't the one that happened at the cardiologist's office. It was the one he took himself at home at 7 in the morning, 3 weeks after he started monitoring. His clinic number and his home number were 22 points apart. 22 points. The clinic was treating a number that was 22 points higher than the number his body actually lived in most of the time. And that raises a question worth sitting with. What does your blood pressure actually look like when no one's watching? Because that number, and the one your arteries experience at breakfast, at rest, in the middle of an ordinary Tuesday, is the one that matters most. And it might be telling a very different story than the one on the printout. If you found this useful, share it with someone you care about. Someone who nods every time they're handed two numbers without fully understanding what they mean. Because now you have something to give them. Take care of yourself, and then I'll see you in the next one.